Hello everyone, this is Jacob. So this is the first chapter in the first lecture of the semester. So please bear with the audio, but I hope that the quality of this will be fairly good for all of you. Also, please note that these slides are essentially taken directly from the publisher, and I've removed many portions of the slides that I thought were redundant or not up to date. What you see in blue text is original, and what you see in italics and in red text are my additional thoughts that I've typed out in addition to what I'm giving to you verbally. I've also added some things to the text of the slides themselves. So I thought that would be a valuable disclaimer as we get started that I won't give on every lecture, but just for this first one so you understand which portions come from the publisher and which portions come from me. In addition to that, generally speaking, whenever you see web links, photos, or references to websites or videos, generally speaking, those are coming from me and won't be part of any quiz or test, but I think they're valuable to your learning. So with that, let's move on to the first slide. So the first concept we're going to cover is essentially what is data, information, knowledge, and wisdom. And because I'm a fan of words in general, I think it's important to point out that data is actually a plural, and the singular version of that word is datum, D-A-T-U-M. So generally speaking, if you're talking about one piece of datum, then it's singular, and if you're talking about a large set of data, then that's the appropriate use. So data is, just like the slide said, characters, numbers, facts gathered for analysis, and you might take action on it later. And the example I like to give just to introduce students is blood pressure. So generally speaking, the number 150, just the number by itself, a discrete number, it's quantitative, that's data in its truest form. Information, you'll hear people use the terms data and information synonymously, but they're not. So information is different. It's data that's been interpreted. So once you say that that number 150 is actually part of a blood pressure reading, it's a systolic reading for blood pressure, putting a label on the number and therefore giving that number meaning makes it not just data, not just a discrete quantitative numeric value, but it gives it a meaning. So now you know that that number, 150, is actually a blood pressure. In this case, we're saying it's a high blood pressure, like 150/95, something definitely out of range. So the third concept is knowledge. And that's when you take information and you synthesize it from several sources and you produce a single concept. And sometimes there's a evaluation of that knowledge. And so because of your studies and because of the evidence and because we have millions of blood pressures from millions of people and we have a lot of information on blood pressure, you can say that you have knowledge to know that blood pressure of 150/95 for a normal adult under normal circumstances is not a good indicator, and that's an abnormally high value for an adult. So you making that determination based on additional information, evidence, etc., and or this patient's trend over time. So if you know this patient normally has a within normal range blood pressure and this is a high value for them, you're comparing the current value against previous values and therefore applying knowledge. The last part of the data, information, knowledge, wisdom hierarchy is obviously wisdom. And so wisdom occurs when knowledge is used appropriately to manage and solve problems. And so the example I give here is if you take evidence in the literature, your own experience, your training as a nurse, which all fall under the category of knowledge, and you take the available information, that blood pressure reading or any other data, and then you use all of that together to treat the blood pressure effectively through management with medication or over the long-term management with lifestyle change like diet and activity. That is using wisdom. So I hope that you can see how these things are all not completely independent, but they're all a little bit different, and they have different applications, and that generally speaking, it's like a hierarchy in terms of going up a level each time. So data is just bits like numbers or letters or points of data, individual sort of numeric values. Information is when you put a label or a meaning on it. Knowledge is when you sort of use those all of that information together to form a concept. And wisdom is when you use that knowledge to reach a goal, or solve a problem, which in healthcare, generally speaking, is treatment of a patient. All right, and so I hope this diagram can help provide a little bit more information, or at least visually represent how I think about data, information, knowledge, and wisdom. And I found this online, so I can't credit it appropriately, but I didn't create this. And I think it's important to think of data as sort of without context, whereas you can see that information, knowledge, and wisdom are within context. And I think that you can see that, generally speaking, you have two sets of people, and you have data and information producers, and then you have information and knowledge consumers. And we'll talk about those two concepts soon in the slides. And I hope that you can see also that with the x-axis being understanding and the y-axis being context, that you can see that, generally speaking, data by itself has very little context and provides very little understanding, whereas wisdom has a lot of context and provides a lot of understanding. And the only other thing to point out is that I hope that you can see around knowledge, there's an extra little sort of pink or red band that says experience. And so as a nurse, when you bring your experience into play, generally speaking, that's part of the knowledge aspect. So healthcare settings are knowledge intensive, and there's also been an exponential growth of knowledge, which we'll discuss in later chapters and also in additional slides. But generally speaking, there's so much more knowledge because with technology, there's a lot more data and a lot more information, and people are also doing research and publishing that research online at a much faster rate than they used to. So there's a lot more knowledge available to a clinician today than there was in the past. Information technology supports evidence-based practice because you can get access to the most recent evidence, the most recent literature, the most recent practice guidelines or standards via your computer or readily available on your unit floor, etc. Much more than you were able to in the past. And nurses are routinely detecting patterns, whether through very empirical research or use of technology as a nurse researcher or informaticist, but also just in your everyday practice. You are, without even charting it down, sometimes pick up on things in terms of patterns with patients or patterns across multiple patients with a similar condition, which helps make you a better nurse because you gain experience over time. And so a lot of times when people talk about their assessment abilities as a nurse or their nursing intuition, it really is a thing where over time they're detecting patterns, and so they're functioning much in the way that a researcher would, except it's just based on their day-to-day experience. And when we talk about evidence-based practice, we'll talk about sort of the synergy between the empirical studies and the literature and the experience that you gain over time as a nurse. But in knowledge work, both of those things are valuable. So some knowledge worker roles are data gatherer, which is someone who collects data. And I would like to say that for the purposes of this slide, an information gatherer and a data gatherer are essentially synonymous. So a lot of times we refer to like a nursing assistant who's going from patient to patient and collecting vital signs. So in that case, we would call them a data gatherer. And if one of you wants to argue that because they're going from patient to patient and they're collecting blood pressure and temperature and respiratory rate, and all of those things have a meaning and a label on them, and that really they're information gatherers, I would say you're right. But for the purposes of this slide, we're not getting too picky about that. An information user is somebody who interprets clinical data and uses it to monitor patients and aid with their decision making. And so generally speaking, this is sort of the bucket that nurses and providers, whether they're physicians, NPs, or PAs, fall into. And then there's a knowledge user who compares data to current knowledge. And generally speaking, this is someone who is a nurse or higher that has a BSN degree or other equivalent or higher degree, because this requires you to have the ability to take the current data or information you have in your setting and compare it to current knowledge, which requires, generally speaking, the ability to go out and query an evidence database like CINAHL or like PubMed to do that comparison. And generally speaking, and I'm sure many of you can attest that you don't usually get that type of training or the ability to think critically about comparing multiple sets of data or comparing what you're seeing in practice to what the evidence says. You generally don't get that training until you're in your BSN program. And then there's another role called a knowledge builder in the book. And this person amasses data to show patterns that can be interpreted using existing knowledge or used to create new knowledge. And so this, generally speaking, is a nursing researcher or a clinical or nursing informaticist, which is what I do. So there's a distinction here, and I'm not sure if this is one of the key points of the chapter, but it's worth noting that information and knowledge management are different. So good information management provides the right information at the right time to the right people. And generally speaking, that is also a good description of what informatics is, providing the right information at the right time to the right people. And a separate concept is knowledge management, which is creating systems that enable organizations to tap into the knowledge, experiences, and creativity of their staff to improve their performance. All right, so informatics, what is it? We went over this in your introductions in class, and many of you said you didn't know what informatics was. And at least according to your book, it says that informatics is the art and science of turning data into information. There are a lot of conflicting definitions of informatics. I like getting information to the right people, the right information at the right time to the right people, displaying it correctly. Some people like to say that informatics is sort of the intersection of people's culture, their workflow, and information technology systems. But while this definition is in your book and it's therefore what your quiz and exam questions are based on, I found a visual representation that I was taught to be more helpful in understanding. All right, so this is the visual, and this was adapted from a book that I had to read in my program at Duke by Shortliff and Simoneau. And what this equation essentially says is that a person with an information resource is greater than that person on their own without the information resource. And in healthcare, the way that we apply that is essentially, and especially in nursing, would be a nurse with their electronic health record, or a nurse with a decision support system, or a nurse with barcode medication scanning is better than, in some way, the nurse without that system. And so this is essentially just saying that having a good information source is always helpful, and that you as a nurse with a good information source is a good thing, and that in this year, because computers are so pervasive, generally speaking, when we talk about an information resource, we're talking about a computer and we're talking about a piece of software like an electronic health record. So there'll be subsequent lectures about safety and quality and how informatics plays into that. But generally speaking, think of this general principle of informatics as a way of understanding what our goal is. But remember the book definition for your quiz, which is that informatics is the art and science of turning data into information. All right, so on the next few slides, you're going to see different iterations of what will probably look like the same concept to you. And rather than read exactly what's on the slide, I want to try to just explain that there are a lot of subfields to informatics. And I'm sure I've mentioned in class that informatics is a concept that's in a field that can be applied to many different sectors. And so there's informatics in the automobile industry. There's informatics in the IT industry outside of healthcare. And in this class, we talk about health and or clinical informatics specifically. And so you'll see a lot of words sort of appended to the front of the word informatics to describe sort of a sub area. And so I describe myself as a clinical informaticist because I typically am dealing with delivery of care. and I work with clinicians primarily. An even more broad term than clinical informatics would be health informatics, because that encompasses more than just healthcare or care delivery, but considers other factors in a person's health outside of when they're being treated. A more specific sub area would be medical informatics. And generally speaking, when you hear about medicine, you're thinking care delivery and you're thinking physician-based. And that holds true in the book's definition as well. So another definition would be nursing informatics, which, just like it sounds, is still informatics, but it's with sort of a lean towards nursing, an application of nursing science and direct care delivery from a nurse, and using informatics um, as a science and as a specialty to enhance nursing practice. And there's an additional concept called consumer informatics. And so when you hear the word consumer in this class, I want you to think of the words patient, or think of the words customer or family member. Because obviously many times your customer, if you're dealing with a child, is many times the family member, parent, caregiver. And so think of the patient, the family, or the customer, whoever that may be, when you think about consumer informatics. And so this subspecialty of informatics is essentially the patient using information that they get online or through a personal health record or through their portal from their provider, and how they use that information to make decisions about their health care. So a concept that we want to unpack a little bit is information literacy. And so the book is going to define this as the ability to recognize when information is needed, as well as the skills to find, evaluate, and use needed information effectively. And as a sort of a general takeaway, I want you to know that as students, this is my primary goal for this course, is to help you develop your information literacy. Because if this is a skill that you have, it's okay to not know the answer to something, or to have an area where you don't know all of the information, whether it's in a clinical context, you're not sure what the best practice is for treating a particular patient, or in the academic context in terms of you're working on a paper or a project for a subsequent class in pursuit of your degree, and you're not sure what the answer is, or what topic that you need to cover for your professor. And so if you can develop the skills to determine when you need information, find good information, evaluate whether or not that information is of high quality, and then use that information correctly, and sort of apply that wisdom concept to apply that information and that knowledge to solve a problem, then you will have essentially met the core requirement of this class. And if you do that using informatics and using information technology, then that's even a bigger plus in terms of your ability to utilize online or computer-based resources to problem solve and to learn. One other key point is that information literacy is not computer literacy. And so I want you to divide out now that, generally speaking, people who are information literate are also computer literate, and many times when they find information, they get it via the computer or an online resource. But someone who knows how to go to the library and look up paper information could be information literate, but not necessarily computer illiterate. My hope is that at the end of this class, because of your use of Blackboard and your ability to go on high-quality websites and also search for articles on CINAHL, that you will have both developed and practiced some level of computer literacy and information literacy. All right, so if you're going to work in informatics at some level, there are some competencies that we want you to be aware of. And so there's sort of an entry level, and those competencies include basic computer skills, use of IT to support clinical and administrative processes. So that could be as simple as using an electronic health record like Epic or Cerner or whatever your institution uses. Access data and charts electronically. support patient safety initiatives using information technology, recognizing the role of informatics in nursing. So just in general, by taking this course and or using the EHR at the hospital or doctor's office you work at, you will have entry-level skills. So if you don't already, by the end of this course, you will be considered an entry-level informaticist or informatician, depending on which term you prefer. An experienced nurse informaticist possesses, again, basic computer skills, supports specialty area like quality improvement and other activities with the use of IT. They use evidence-based databases. The one that will promote most often is CINAHL. They promote the use of technology applications. They use information systems and work with IT staff to enact system improvements. So if you are a super user on your unit, you might fall into this category. But generally speaking, this is mostly people who have who support IT or informatics activities part-time as sort of a clinical expert on their unit. And oftentimes these people are bachelor's prepared nurses or higher because using an evidence-based database is one of the competencies, and oftentimes you don't get into that practice until after you're trained with your bachelor's degree. So an informatics nurse is proficient with informatics applications to support all areas of nursing practice. They're familiar with fiscal management and oftentimes basic budgetary and project management concepts. They have integration to multidisciplinary language and standards of practice. They have critical thinking skills, data management skills, and system development and computer skills. So generally speaking, these are people who are full-time on the informatics team at their facility. Now, an informatics nurse specialist is sort of the equivalent to a nurse practitioner or a clinical nurse specialist, except instead of clinical care being their specialty, information use or informatics is their specialty. And so they have a more sophisticated level of understanding and skill set. They're innovative. They conduct informatics research, and they generate informatics theory. And as an example, this is the role that I fall into. It usually, generally speaking, people at this level of expertise are certified in informatics, or they have graduate or postgraduate education in informatics, which is usually a certificate or a master's degree, and they have many years of experience. So this is something that, if you're interested in informatics, that's sort of a career trajectory that you can follow to develop your skills and become an informatics nurse specialist. But like I said, most students in this class are already entry level or will be by the end of the course, and many of you will move on and maintain your clinical roles and move into that sort of experienced place if you're working in a capacity where you're a super user or you're informing the IT staff about ways that they can improve their design. But these are some sort of reach categories that if you devoted your career towards developing your skills in informatics, these are some roles that you could potentially fill down the road. There are a lot of forces or priorities in healthcare that are driving the use of information technology and therefore the role as nursing informaticist. And those include, and this isn't an exhaustive list, but requirements related to patient safety or improvements in patient safety and quality. The nursing shortage. There are some advantages to using information technology that alleviate some of the concerns caused by the shortage. The move toward evidence-based practice, so creation of evidence and quick access to evidence, and then including that evidence in your applications as clinical decision support, which we'll cover in a future lecture. Genomics, which is essentially just the study of the human genome, or genetics to determine what disease somebody has, the state of it, the likely course of that person's treatment, or what treatment they need exactly. And so I previously worked with an oncologist who was an informaticist, and he was describing to me a case where There are genetic markers in the treatment of breast cancer, as an example, that um, are more refined and more predictive than the sort of more historic staging criteria. And so people used to say, well, you're stage 1, 2, 3, and many people often thought that if it wasn't caught until it was stage 3 or 4, that you had really bad chances of recovery. And if it was caught at stage 1 or 2, you had really good odds. And while that general principle still holds true, in some cases, you can run genetic tests on these patients and look for specific genetic markers that would show you that even though they caught the cancer at stage 1, this particular genetic marker, perhaps 80 to 90% of the people who have that marker end up passing away, unless they have a more aggressive treatment. Or likewise, you may catch the cancer relatively late, but the genetic markers may indicate that a more conservative treatment has been very, very effective, even when that particular cancer is caught um, later in its progression. And so that's a really exciting and growing field in terms of really customizing the care that you provide for the patient based on their genetic sequence, and using genetics in clinical care in real time and doing it in a cost-efficient way is only possible through the use of information technology. So quickly to run down the list, other forces include demands for high quality and low cost care, increases in research, and then pay for performance, which is also sort of linked to that low cost and high quality. And the government is making some changes to incentivize higher quality and lower cost instead of higher volume, and just providing more services. And that'll be a large portion of the lecture when we get to regulation and accreditation and other concepts like that. But it's important to know that's one of the drivers in information technology. So the push for patient safety, some things that are in place are technology to improve accurate patient identification. Many of you have probably heard of CPOE, or computerized provider order entry, e-prescribing or electronic prescribing of medications from either the inpatient or ambulatory setting, barcode or RFID medication scanning or administration, or decision support software or clinical decision support. You'll hear it abbreviated CDS or DSS, which is the system basically making clinical recommendations or providing additional clinical information to the generally a nurse or a physician, so that their decision may be changed by additional information or confirmed, and has been shown in many instances to improve the quality of care that a patient receives. So the push for evidence-based practice is essentially based on a desire to move towards proven interventions. It's driven by the demands for greater quality and cost efficiency, and provides greater consistency in care from institution to institution or provider to provider, clinician to clinician. So everyone is practicing to a standard or a guideline that's based on proven evidence rather than individuals deciding what they think is the best care based on their experience alone. So I don't want to diminish the value of someone's experience as a nurse, and we'll talk about that's part of evidence-based practice, but basing your standards and your guidelines more on the evidence than anything else. And a good example of this that I've experienced even in my short career is when I was in nursing school, we saw multiple examples on critical care units where patients were on ventilators, and in some units they instilled saline or sterile water into the patient's trach tube, and in other units they didn't. And the evidence on that has actually been out for quite some time that you don't want to instill liquid into the patient's trach tube when they're on a ventilator, because it increases the rate of ventilator-associated pneumonia. But many nurses have done that for a long time because they thought that when you instilled a liquid first, and then you suctioned out that trach, that they got more out of the trach tube, and they thought it was beneficial to the patient. And what the research has shown that you get an increased volume out of the trach tube because you're instilling the volume in, and that some of that liquid is left behind and provides a really good growth media for bacteria. And so patients who have liquid instilled when they're on a ventilator have higher rates of ventilator-associated pneumonia. Now, despite the fact that the evidence has been fairly straightforward, there are many nurses who have still not adopted that practice, and many respiratory therapists who have not adopted the practice of not instilling that sterile saline into the tube. And that's something that you can work on in your own institutions and look up the evidence and try to get a policy changed in your own hospital if that hasn't been changed yet. So really quickly, genomics, we already talked about it a little bit earlier, but the study of genes and their function and the ability to subsequently tailor treatments to the individual, to their genetics. It essentially comes from demands for quality and efficiency, and it's a means to provide even more tailored care to the individual. So there's an understanding now that not everybody with the same disease will have the same progression of their illness, and that in some instances the progression of the illness is based on particular genetic markers that a patient has. And this is especially true with childhood illnesses, genetic abnormalities in the child, and then also cancer are the areas that I'm most familiar with genomics being applied. So there are a lot of demands from customers for quality, meaning safe and affordable care, so low cost. And from that have stemmed multiple initiatives, one of which is online report cards. So an example of one is available via CMS, so Medicare, and it's known as Hospital Compare. And so I listed the website here. You can essentially go on that website and look up government reported quality data on essentially any hospital that accepts Medicare patients, which is essentially all, and compare some basic statistics. Now, there are obviously always caveats with those statistics, but it does give you a general feel of common quality indicators comparing multiple hospitals. And it also is a move in the right direction in terms of consumer transparency. So prior to websites like this, it was very, very hard to determine which hospital had higher quality than another. And we usually made those determinations based on our own prior experiences with that hospital, whether or not we were satisfied with our care or our family members' care, or we would hear stories from our friends about whether or not they had a great experience or a bad experience at a particular hospital or from a particular provider. So some other things include remote clinical monitoring, which we'll talk about in later lectures, disease management, and then again, research. So we've arrived at the last few slides in the deck, and there's a quick summary of the benefits of informatics. It supports work processes and hopefully makes processes more efficient. You have improved records, and by improved I mean more accurate, more up-to-date, better access to records, decreased redundancy, and oftentimes you hear multiple imaging studies or multiple lab tests done because they didn't have access to good information, and so we can reduce that with technology. More convenience, improved data collection, prompts to improve documentation. So unlike paper, a system can tell you when there's something that you're supposed to be documenting and you haven't yet. Improved safety through better patient identification, oftentimes barcode scanning. Decision support, so the system telling you whether or not you're following evidence-based practice and tracking. And then improved communication within the team and with the patient, and improved access to information by both clinicians and consumers or patients. So information technology expands access to all types of education, primarily through the use of the internet. And there are formal and informal informational programs that exist to promote informatics skills. And so throughout this course, you'll hear me reference several websites or professional societies or blogs or wiki entries for where to find useful information. And so I hope that you keep those in your back pocket as you progress in your understanding of informatics, to sort of develop your skills. And then if any of you are interested in informatics as a career and want to discuss potentials for continuing your education beyond your bachelor's degree, know that you can always reach out to me via LinkedIn. And I think I've provided that information to the class. Um, and also, as long as my UD Mercy email is active, you can email me there, and ask any questions you have about continuing your education or training in informatics beyond this class. So in the future, information technology will help clinicians to develop needed competencies. We will develop and implement information technology where it doesn't exist. We will generate new knowledge. There will be new roles with consumers, and we'll implement new technologies like the use of genomics, robotics, wearable monitoring devices, which is essentially already come to fruition, and we'll make developments in educational technology.